this, we have been working together on making this presentation. There's a new faculty member of ours here. I think some of you people know him.
With my honorable colleagues. I've been asked to talk about the approach to Tenosynovitis Syndrome and Entrapment Syndrome. It's a bit different from the presentation which was presented earlier. In that presentation, your brain was bombarded with the chemistry, but I'm just going to talk about something mechanical. Both the problems are mechanical. So, first thing is how to define about tenosynovitis. Tenosynovitis is inflammation of tendon and tendon sheath. Tendon is basically a rope-like structure which attaches muscle to the bones over the joint. And tenosynovitis is inflammation. Basically, tenosynovitis, this inflammation can be infective and non-infective. But I will concentrate or limit myself to non-infective entity. Next, please. Objective of this presentation is that by the end of this session, each participant should be able to recognize different tenosynovitis and entrapment syndromes. Number two, they can be able to properly educate their patients, and they can identify those patients who need specialist referral. And most important, they can understand the principles of injection therapy for these conditions. Next, please. Tenosynovitis syndrome. Basically, there are a lot of tenosynovitis syndrome, but the most important which we encounter are trigger finger, decurvence, tennis and golfer's elbow, bicep tendinitis, rotator cuff tendinitis, Achilles tendinitis, and plantar fasciitis. Though it's a fasciitis, but pathologically it's the same entity which we do see in the tenosynovitis. Next, please. Trigger finger. This is a very common problem, and I think it's the most common tenosynovitic problem which we encounter. Its pathophysiology is basically there is a swelling of flexor, either flexor tendon or tendon sheath, and the tendon find difficulty of passage through the pulley. It's just like as you are putting a rope into a tunnel, and they find difficulty while passing through it. So it's basically the same problem in the tenosynovitis. Next, please. We do see this trigger fingers in the children, which is a congenital form. The patient is unable to extend the IP joint of his thumb. 70 to 80% of these children, the problem solved on its own. About less 20% that will resolve on its own in 3 years. But the child who keep on presenting with this problem after 3 years, surgery is indicated. That is, we just slit the tendon sheath and allow the free movements of the tendons. This is a typical picture of a trigger finger. Trigger finger is most commonly involved the ring finger. Second involvement is the middle finger, but we do see this problem in the other fingers as well. Once we see this patient trigger finger, 2-3 questions immediately come to your mind. You ask this patient, what is his profession? Normally this problem is seen more commonly in the manual workers. Then this thing comes into your mind. Are you diabetic? Because this problem is more common in the diabetic. But we do see these problems in the others like Dupuytren's, contractures, and sometimes the etiology is not known, which is developed idiopathic. This is sort of a picture. Normally, what we see in this problem is we see a filial nodule at the metatarsophalangeal joint. It's usually tender and it's palpable, and then we just ask the patients. You can even palpate and even palpate the nodules and palpate the grating sounds once he try to flex the fingers. This problem, it can be sort of arrest of movements can be in the flexion or it can be in the extension form. It can be in both. Next, please. This is again another slide just to show you the pathology. The synovium is swollen. This is again another slide just to see the pathology. What are the signs and symptoms in tenosynovitis? As I just mentioned about you, that it's usually a rest either in flexion or extension, and this is usually worse after rest. The patient complains more bitterly about the triggering in the morning, but gradually they say it resolves. Then this triggering is transmitted to DIP joint. Usually the DIP joint is in the flexed position, or it even entire finger may get locked. Next, please. So, how to manage this problem? Normally, we ask the patient to give a rest, initial stages, give non-steroidal anti-inflammatory drugs, and most of the people, they do respond, but the people who don't respond, we offer them the injections, steroid injection. 80 to 90% of people, they do respond to steroid injections into the tendon sheath, and very occasionally we have to repeat. But refractory cases, if the patient don't respond to steroid injections and the time we have gained and he is not responding, then the ultimate solution is the surgical intervention. In the surgical intervention, we can do it under local anesthetic, but it should be under tourniquet control. It's a quick procedure, and we have to be very careful about the nerve, which just passes along the tendon sheath, and there is always a danger of injuring the nerve. So this is the technique. It's just how to inject the tendon sheath in trigger finger problem. It's usually at the metacarpophalangeal joint, and we have to inject it from distal to proximal. We go through the skin, subcutaneous tissue. After preparing the skin properly, we have to go from the distal to proximal and just feel for the resistance. We should avoid the tendons itself and then inject this area. And we have to, we have to tell the patient. Sometimes they come and they say, we have got tingling and numbness of this after this injection. So we have to tell them we normally inject local anesthetic and steroids, and there is a likelihood of getting some tingling and numbness, but that will gradually go off. Next, please. The next common problem which we encounter in our practice as a general practitioner or even as an orthopedic surgeon is Decouples disease. Decouples disease is basically it is the thickening of synovium of abductor pollicis longus and extensor pollicis brevis. These two tendons travel together and they are enclosed by one common sheath. And due to repetitive stress, there is some swelling of the tendons or the tendon sheath, which results in pain at the radial side of the wrist, particularly at the styloid, and the patient complains bitterly about the pain in this area. We usually encounter these problems in the women, especially in the young women after they give the birth to a child, or to the grandmothers who look after the grandchildren, because the way they pick up the child is they just ulnar deviate, and they just causes more stress on these two tendons, and so we see these problems more common in these two groups. So pathology I've just discussed. Causes, as I told you, it's a repetitive sprain injuries. Symptoms is again pain and swelling over the thumb side of the wrist, difficulty in gripping, and next please. How to diagnose the signs is known as Finkelstein's test. How to perform this test is we ask the patient to make a fist and put his thumb into the palm and then ulnarly deviate it. The patient would complain bitter pain on the styloid area. Next please. Treatment is we have to tell the pathology and we have to tell the patient what not to do. Try to avoid these sort of actions, and we again give the general measures. We ask the non-steroidal anti-inflammatory drugs, then moist heat, local applications. Most of the people, they do respond, but in the resistant cases we have to inject this tunnel, and they have got dramatic relief with this steroid injections. Next please. So how to inject the Decouples syndrome or Decouples Tenosynovitis? We have to go through the first dorsal space, dorsal extensor space, and then direct it towards the styloid process after obviously preparing the skin, and go through skin, subcutaneous tissue, and then into the tendon sheath, and give the steroid injections. Most of the patients, they do respond, but while we give steroid injection to these patients, occasionally we have to warn them, because sometimes after steroid injections and you find some fatty regeneration, and you find some discoloration of the skin. So you have to warn the patients, but again you can reassure. Most of the cases the discoloration would disappear. It takes 3 to 6 months, but the patient, sometimes they come after steroid injection, they say, doctor, what have you done? It's a discoloration there. You have what have you done? So if you explain to them beforehand, then probably they will have some peace of mind. So the next problem which we encounter is tennis elbow and golfer's elbow. This is also a common problem. Next please. Tennis elbow is basically inflammation of the origin of common extensor origins. So basically you see this problem in the lateral side of the elbow, and basically you see these problems in the tennis players, because once they just give a shot in the reverse swing, they get repetitive strains in this way, and so they get inflamed at the origin, and then inflammation can go into the muscles. And the golfers, as in the golfer's elbow, there is more strain on the medial side of the elbow, and there is more tenderness and more pain on the medial aspect of the elbow. Etiology is repeated overuse of forearm flexors, extensors, minor tear of tendinous attachments. Then we can see these problems in the golf or racket sports, throwing sports, right. And then is the symptoms. The patient usually present with dull ache in the tennis elbow on the lateral side, and in the golfer's elbow on the medial side. It is gradual in onset, and it's worst after play or after the games. But this pain can radiate into the forearm. Next please. Signs are there is maximum tenderness which is localized over the affected epicondyle in case of tennis on the lateral side, and on the medial side it would be the golfer's elbow. But we can elicit these problems by provocative maneuvers. In the lateral epicondyle, we extend the wrist and supinate against resistance. The patient will complain of pain in the lateral side of epicondyle. And in the medial epicondylitis, that is golfer's elbow, we flex the wrist and pronate against resistance. The patient would complain more pain about the pain on the medial side of the elbow. The management for this problem is again, initially we give them non-steroidals and some ointments, and then ice cold. Most of the people, they do respond to this problem, but if there is any, the patient don't respond to this normal management which we offer, then the next thing which we can offer them is steroid injections. We can also tell them to do a bit exercises which is painless passive wrist flexion and progressive resisted wrist extension. These are the exercises which we can show them. In the injection, sometimes, I mean not now, previously what they used to do was they immobilize the elbow. In the tennis elbow, they immobilize wrist in the 10-degree extension, elbow at 90-degree flexion, and in supination form, because in this situation they feel like the tendons, they get rest, but no more practice this sort of treatment now. Next please. So injection, what injection which we use is we inject 1 ml of lignocaine or xylocaine 1%, and steroids we sometimes use depomedron 1 ml or Kenacort. We mix them and then we prepare the skin. In case of tennis elbow, what the position of the patient would be, the arm should be adducted at side, elbow flexed at 45 degree, and wrist pronated. But in the tennis elbow, what we do is we put the arm in the abducted position, elbow at 45 degree flexion, and wrist supinated. Next please. We have to insert the needle perpendicular to the skin, insert to the bone, then withdraw 1 to 2 millimeter, and then inject this solution. Next please. This is what we are showing is the injections. That is the maximum tender point where we have to inject it. Next please. This is again steroid injections. Next. Again. Next please. Right. I would say about 95 to 98% patients respond to these sort of measures, but we do come across with these patients that after repeated steroid injections, the patient don't respond and they are just really after you. So in these cases, we can offer them the surgery, and surgical intervention is basically what we can offer them is release of the common extensor origin in case of tennis elbow, and common flexor origins in case of golfer's elbow. Some people do recommend even we have to take slice of bone, so what we call is epicondylectomy. The results for this sort of procedure is again not 100%. It's, I would say 70 to 80% people get better, but patient do we do see the results of failure as well. Next please. Now the next problem which we encounter is biceps tendinitis. I mean, though the bicep is considered to be the sign of power, but they do get some problems as well. This is a typical picture of biceps. It's usually the long end of biceps which gets inflamed. Long end of biceps gets through the bicipital groove. It's usually surrounded by the sheath, the synovial sheath, and we do get inflammation of this tendon. To differentiate this problem from the frozen shoulder, in the frozen shoulder, the movements are obviously very restricted, but in this problem, if we flex at the elbow and supinate and flex the elbow, patient do complain of pain at this particular side. And so, next please. Symptoms are similar to any other tendinitis. Provocative test which I have shown you. Next please. The treatment will remain the same, that is we give non-steroidals, local and physiotherapy, but the patients who fail to respond, we give a steroid injection into this area. This is deltoid muscle, then is the pectoralis, and that's the long end of biceps where we inject. Next please. Then we have to tell them the rehabilitation exercises. Next please. But as I told you, the steroid has got its own problems. It can cause rupture of the tendons, and we do see these problems as an insult from steroids. Next please. The next problem which we encounter is rotator cuff tendinitis. There are basically 4 rotators: supraspinatus, infraspinatus, teres minor, and subscapularis. Subscapularis is attached to the lesser tuberosity, while the other 3 rotator cuffs they get attached at the greater tuberosity. Next, please. Pathophysiology is there is degenerative changes, and we do see these either as a tendinitis, and sometimes it's difficult to differentiate it from the ruptures of the rotator cuffs, and sometimes we do see calcification of tendons as well. Next, please. Symptoms of rotator cuffs are pain, worse at night, shoulder tenderness and atrophy. They try to droop the shoulder because basically the purpose of the rotator cuff is to stabilize the shoulder in a bit upward position. It's basically a dynamic stabilizer. So if that's not working, the patient droops the shoulder. Patient is unable to lie on the affected side. Refer pain to the deltoid. Next, please. Signs is in the supraspinatus case is maximally tender over there. Then is next, please. Shoulder X-rays. If we do get the X-rays of the shoulder, we see sclerosis at the tuberosity, and sometimes this problem is associated with the degenerative changes at the acromioclavicle joint, and we see hooking of the acromion because we see degeneration under the surface of the acromion. So as I discussed about it, that we have to differentiate it from the other two entities, that is rotator cuff calcification and rotator cuff rupture. Management I've discussed. Next, please. Prognosis. I mean, if it's a tendinitis, you must anticipate the improvement with these measures in 3 to 5 weeks. But if it doesn't, then there is a chance that it may be a rupture. Next, please. This is again another very interesting condition, which is what called as acute calcific tendinitis. It's really a very painful condition, and we have been taught if you see this condition and the patient wakes you up even at 12 midnight, you must see the patient, you must relieve the pain because the pain is very, very bad. The diagnosis for this sort of problem is you do see calcification in this area. What in the acute condition, what we can do is we can even aspirate at the maximum tenderness point. We insert the needle, aspirate, and then inject steroids, and patient do get a dramatic relief from this condition. Next, please. Then in the low feet, in the low limbs, tendinitis, which we encounter, especially in the athletes, is we do encounter adductor tendinitis. We do encounter patellar tendinitis, but most common tendinitis which we encounter in the low limb is Achilles tendinitis and plantar fasciitis. So Achilles tendinitis, as we can see, Achilles tendon is attached to the posterior surface of the calcaneum. Is usually painful. Patient feel more pain on dorsiflexion, and there is tenderness at the Achilles tendon itself. Next, please. Etiology for this problem is a chronic overuse of calf muscles, common overuse injury. You can see in the runners who have just started running, dancer, gymnasts, and tennis players. Heel pain and stiffness at the Achilles tendon, which is worst at strenuous exercises, and the patient may walk. You see them with uneven gait. Management for this sort of problem is again non-steroidal. We ask the patient to use high heel shoes that give a rest to the tendon, and physiotherapy. One important thing which we must not do is inject this area. That is the only tendinitis perhaps we shouldn't inject, because we do see ruptures of the Achilles tendon in the patients who have these problems. Next, please. The next problem which we commonly encounter is plantar fasciitis. The plantar fascia is normally attached at the anteromedial aspect of the calcaneum. Patient presents with heel pain. Normally there is a tenderness at the maximum tenderness at the anteromedial aspect of the heel, and sometimes it radiates to the medial arch of the foot. Next, please. Symptoms are from dull toothache to burning pain, and sometimes they do complain of severe pain. The pain usually is they complain in the morning. First step once they start, they says they get the heel pain. Pain location is, as I've discussed. You do encounter both heel pains as well, that is in the plantar fasciitis bilaterally. So the patient who presents to us with heel pains, immediately something which comes into our mind is we must rule out the other pathologies which can be contributing to this problem. We do see gouty arthritis as a presenting complaint as a heel pain. Then we can test as a provocative test. Pain worse with first few steps in the morning, pain may be worse at day ends, pain worse with first steps of run, pain worse with prolonged standing. Next please. Signs are again, as I mentioned, that is the focal point tenderness. Provocative maneuvers which we can do is passive dorsiflexion toes and stand on the tips of toes causes pain in the heel. The other thing which is quite confusing with us is we do get the x-rays of foot and we see the calcaneal spur. But calcaneal spur, it can be an incidental finding. It's not must that calcaneal spur presence is must for this problem. I think it's about 30% of calcaneal spur presents with plantar fasciitis, but 70% they don't have any calcaneal spur, but they do have this problem. As we were just discussing about the calcaneal spur, that it can be an incidental finding, but it's not must for making the diagnosis of plantar fasciitis. Next please. About the management of the plantar fasciitis, it's usually a prolonged recovery expected. It's a prolonged problem and it may take 6 to 18 months for this problem to sort it out. We can give them ice therapy, we can give them a relative rest, we can advise them to avoid the provocative activities, that is long standing, and they must change the hard shoes and they should avoid the hard surface to walk around. We do prescribe them some insoles. We give them either a sorbitol heel pad or silicone heel pad, that is just to give them a bit cushion to this area. And sometimes in the pes planus, we see this problem more common in the pes planus, so we give them medial arch support. Then again we advise them some stretching exercises, which is dorsiflexion at the ankle joint, which we can show you in the next please. These are the exercises which we tell them, that is if gastrocnemius and soleus exercises, as somebody is pushing the wall, so they are just standing on the stairs, but the heel shouldn't be on the stairs. Then elevation, standing on the elevator. Then it basically, the whole purpose is that your foot should be a bit dorsiflexed. Then in the morning we can tell them to use the towel and try to passively dorsiflex his ankle. Then is the friction massage, and then roll his foot on this bar or something round. So these are the exercises which we give them, and the literature do say that we get better, as good results with these exercises as with steroid injection. Next please. Then is we can use the posterior splints, we can use the heel cups, and as I mentioned, we can use the medial arch supports. In resistant cases, sometimes we immobilize the ankle and foot, and we give them short leg walking cast for 6 weeks, but it's no more practice now. If the patient don't respond to normal conservative management, which includes non-steroidal and physiotherapy and change of shoes and heel pads, then we offer them the steroid injection. It's a very painful injection because plantar area of the foot and the palmar aspect of the hand, they are the most sensitive area, so patients do cry once you give them the injection, but they do respond. I would say about 80 to 90% patients do respond, but it can reoccur and then you have to repeat. In the resistant cases, if the patients don't respond to any of the measures and you keep on giving them reassurance and they don't believe in you, then next step is a surgical intervention. That is, we do a percutaneous plantar fasciotomy. But again, the results for this procedure is, I would say, around 80 to 90%. It's again, we can't guarantee the patient that there is chances of 100% to get the cure. Next, please. The inflammatory conditions with bilateral heel pain, as I told you, patients do present with bilateral heel pains. So we have to rule out these conditions in these problems: ankylosing spondylitis, psoriatic arthritis, reactive arthritis, rheumatoid arthritis, gouty arthritis, SLE. So these things cross our mind once we see these patients with bilateral pain. But obviously, these diseases are going to have other symptoms and signs. How to inject steroids in the plantar fasciitis is find the maximum tenderness area and go from the medial aspect of the heel, hit the bone, withdraw, and then inject the solution. Next, please. Right. The next interesting and common problem which we encounter is entrapment syndrome. It's usually entrapment neuropathy. Next, please. So what is entrapment neuropathy? The neuropathy is caused by physical compression or irritation of major nerve trunks and peripheral nerves, producing distant nerve pain symptoms. There are certain sites in the body which are more likely to produce nerve entrapment because of its anatomical vulnerability. It's the anatomy of the site from where the nerve passes that contributes more to the peripheral neuropathy. Next, please. So the common sites of entrapment which we encounter is a thoracic outlet syndrome, which is we do see a cervical rib syndrome, or what we call as a thoracic outlet syndrome, ulnar neuritis, carpal tunnel syndrome, meralgia paresthetica, common peroneal nerve entrapment, dorsal tunnel, and Morton's neuroma. But I think the most common peripheral neuropathy which we encounter is usually a carpal tunnel syndrome and ulnar nerve neuropathy. So this is the thoracic outlet. We see the brachial plexus and the blood vessel. They passes through the scalenus anterior and scalenus medius. And underneath is the rib, and sometimes we do encounter cervical rib, or we do encounter a ligament, a strong ligament, which can cause the compression at the thoracic outlet. Next, please. Thoracic outlet syndrome, the patient can present either by vascular insufficiency, or they can present with edema of the arm, and they can present with tingling and numbness in C8 and T1 area, because that is the maximum compression which this cord encounters. And how to recognize this problem is sometimes you can even palpate the cervical rib in the supraclavicular fossa, but we can do a provocative test. We abduct the arm, externally rotate the elbow, and ask the patient to look to the other side, feel for the pulse, radial pulse. The radial pulse will become feeble. So that depicts that there is some problem at the thoracic outlet area. Then we can do the test. The test would include normal X-rays, MRI, and if we think about the patient don't respond to conservative management and he is having severe problems, then digital angiography just to see the relationship between the trunks and the arteries. Next, please. Conservative management, as with any other problem, is that we should ask them to avoid the provocative activity. They shouldn't bring their arms above their shoulders. We do prescribe non-steroidal, anti-inflammatory, muscle relaxant, physiotherapy, and now we can give a gabapentin or B complex. The patients with minor symptoms, they do respond to this problem, to this regime. Next, please. And then the surgical management, in the surgical management is cervical resection, is just really to remove the cause which is offending these structures. The next problem which we encounter is a suprascapular nerve entrapment. Suprascapular nerve neuritis we do encounter it. You have to differentiate it from the other shoulder condition like rotator cuff tendinitis or adhesive capsulitis. But we get tingling and numbness in the periscapular area, and the patient tend to droop his shoulder, which we normally see this problem mainly in the ladies. If the symptoms are severe, then the treatment would be a surgical release, because suprascapular nerve is stretched at the transverse ligament of the suprascapular notch. Next, please. So this is the suprascapular notch, and the nerve is just acutely bended in this area, and causes this periscapular numbness and pain. Next, please. Next, please. Then the next common problem which I mentioned is cubital neuritis. It is normally a compression or irritation of the ulnar nerve, and we occasionally see median nerve entrapment at this area as well. Next, please. If we just see the anatomy of the ulnar nerve passes behind through a fibro-osseous tunnel. Okay, so this is the fibro-osseous tunnel. There is an arcuate ligament which have been incised just to make the nerve free. So if there is any pressure at this area, compression, the patient will complain of tingling and numbness in the ulnar nerve distribution, that is little finger and medial half of the ring finger. They do complain of pain on the medial aspect of the forearm, and sometimes you get, if it's severely compressed, we do get wasting of the intra-osseous muscles. Patient's grip is poor, and the treatment, if it's just minor compression, then we do conservative management. That is, we ask the patient to avoid flexion at the elbow. They should keep their elbow straight, avoid the pressure areas on this side, and non-steroidal, B-complex, and things like that. But if the patient fails to respond to these measures, then best thing is really to get EMG studies and nerve conduction studies. If those confirm the diagnosis, then the treatment should be the surgical intervention. That is, either we do release the nerve, or we anteriorly transposed either subcutaneously or either submuscularly, so that we sort out this problem surgically. Next, please. Next, please. Carpal tunnel syndrome. This is a very common problem, and we see these problems mainly in the females. Patient usually comes with tingling and pain in the median nerve distribution. Median nerve distribution is thumb and 2.5 fingers. So this is the area of median nerve. Patient complains of tingling, but they can even present with tingling even in ring, or even in index or in middle finger. So it's not much that it should be, but we have to see the symptoms, severity of the symptoms. Patient complain of pain which is radiating to the forearm and even to the shoulder, and along with they complain of tingling and numbness. They complain bitterly about the pain at night. I think most probably at night their activity is less, so there is more edema, and that causes more problem. And second thing is, if they sleep with the wrist in the full flexion, that causes more compression on the median nerve, and the patient gives these symptoms. Next, please. Epidemiology is, it can be bilateral in 50% of the cases. is associated with workplace repetitive hand activity. We do see these problems in computers, operators, and manual workers. It can be associated with other pathologies like we do see in diabetes, in other conditions like hypothyroidism, and even in tenosynovitis, rheumatoid arthritis. We do see these conditions associated with it. Patient complaint of hand paresthesia occurs in 30% of computer users, but only 10% of these meet criteria for carpal tunnel, and only 3.5% of these have abnormal EMGs. Next, please. As I just mentioned about associated disorders, which we have to rule out with this problem, and it's more common in these conditions like hypothyroid, diabetes, acromegaly, rheumatoid, gouty, amyloidosis, multiple myeloma, and we do see this condition in the third trimester of pregnancy, but we must reassure the patient that the symptoms would subside after delivery. Next, please. Next, please. Next, please. Signs: sensory deficit over median nerve, 2-point discrimination. It's a very sensitive point. If we can, this 2-point discrimination is positive, then it's about 100% specific. Then I think even we don't need to do any further investigations. Tinel sign is sensitivity is 70 and 94% specific. Tinel sign, what we do is we tap gently at the area of the nerve, and that causes tingling and numbness in the median nerve distribution. And then the next test which we do is a Phelan's maneuver. Next, please. Next, please. Okay. In the Phelan maneuver, what we do is we just hyperflex the wrist for a minute, and then the patient would complain of typical symptoms of a carpal tunnel. This is the Phelan test, flexion test. Next, please. And this is the Tinel test. We just gently tap this area. Next, please. Okay, just behind, please. Next, please. Yes, this is the anatomy. If we just look at the anatomy, it's the carpal bones and the transverse ligament, and there are 8 tendons. There are 8 tendons which pass through this tunnel with this nerve. So if any pathology with these tendons in tenosynovitis, or any compression or any abnormality along the bone tunnel, it's a triangular bone tunnel. Any abnormality with this problem can cause carpal tunnel syndrome. We do see these problems even in the malunited Colles fractures because of some disturbance in the anatomy. Next, please. Next. We do the radiology just to evaluate if there is any local bony abnormality, and then is EMG study, nerve conduction studies. Next, please. Management. General management is again conservative, that is non-steroidal, anti-inflammatory, and just educate the patient to avoid hyperflexion, avoid any provocative activity, and if there is any other pathology which can contribute to this problem, we do eliminate that. So avoid repetitive trauma, avoid the extremes of wrist flexion or extension, and yes, we do see this problem in the vibratory tools used particularly in the machine operators. Next, please. We give them a wrist splint, and the wrist splint that is to maintain the wrist in the neutral position. These measures they only matters for a temporary period really. Next, please. This is the wrist splint which we prescribe for temporary time for the carpal tunnel syndrome. Next, please. We do give a steroid injection for carpal tunnel, that is, and sometimes if the patient is not prepared for any surgical intervention and he is not responding to local steroids injections, then we do give them systemic corticosteroids. Next, please. This is how to give injection of for the carpal tunnel syndrome. If we just see, this is the palmaris longus tendon, this is the flexor carpi ulnaris. So medial to palmaris longus, at the proximal crease of the wrist, stick a needle in. It avoid the nerves. It should be just around the nerve. So give these injections, and patient do respond to this sort of therapy. Next, please. But I think that if once the diagnosis is confirmed and we are sure that this is the problem, then the answer is the surgery, that is we release the carpal ligament. So this is the carpal ligament. We just go in longitudinal skin incision between these two fingers, straight incision starting from the crease up to the mid palm, and just encounter the carpal ligament, just incise it, and the nerve is free, and that gives relief to the symptoms. Next, please. Right. Next common problem is myalgia paresthetica. This is caused by compression of the lateral femorocutaneous nerve of the thigh. It can be result due to the direct injury. We see these problems in obese people and the patients who repetitively flexed his hip, and even in the hernia surgery. Next, please. If we just see the lateral femorocutaneous nerve, it passes through the inguinal ligament and causes compression there. The patient presentation is really very typical. He can map out the area. He says, "Doctor, I've got burning sensation in this area." He can just map out the area, and tingling and numbness in this area, and then the diagnosis is made as, "Oh, you suffer from myalgia paresthetica." Management for this problem is, next please. Next please. Causing burning, numbness, and paresthesia. Response to the patient, local steroid patient respond to non-steroidals and ask them to reduce the weight and avoid the provocative activities, and if they don't respond, then we give the steroid injection. The patient do respond, but in the cases which don't respond and patient bitterly complains of the pain, then we can release this nerve. Next, please. Superficial peroneal nerve entrapment is rarely we see this problem as, next please. If we just see, this is the common peroneal nerve. It branches into deep peroneal and superficial peroneal nerve. So the peroneal ligament or the peroneal reticulum, they compresses this nerve and causes tingling and numbness in this area. If the patient bitterly complains of pain, then we can offer him a steroid injection or release the constricting band which causes this problem. Next, please. We do see Morton's neuroma. Next, please. If we just see, back please. If we just see Morton's neuroma, it's basically a misnomer. It's not a tumor. It's basically a fibroneuritis. If we just see it under histology, there is a thickening of a nerve in this area, and there is a lot of tenderness. Patient bitterly complains of pain on walking, confirmatory diagnosis, if we have to opt for any surgical intervention, is the MRI. MRI is very sensitive test for this problem. Next, please. So, severe pain in toe areas, paresthesia and numbness, palpable nodule in the interdigital cleft. Next, please. So, management is, we do give an orthotics to avoid the pressure in that area. Steroid injection do have some role, but if the patient don't respond to these measures and bitterly complain of any pain, then we can excise it, but we have to warn the patient it can result in numbness in that digital distribution. I'm grateful to you. Thank you very much.